Respected seniors and dear friends, first of all I apologize for being late today. The topic of the day is management of asymptomatic hyperuricemia. Now in our day-to-day practice, without even intending to get a uric acid test done for some reason or the other, we find that most often the renal functional tests, they do show that the uric acid is on the higher side, and we absolutely have no idea as to what has to be done regarding the treatment, whether the treatment has to be initiated or whether one must, there are no clear-cut guidelines as to when one should start the treatment for the same. So today I will try and clarify certain doubts we all had. Now hyperuricemia is defined as abnormally high levels of uric acid in the blood. The cutoff which has been taken for the same is 6.8, because at this at our body's pH and at 37 degrees centigrade, this is what the level of uric acid is in our body. It is a poorly soluble substrate, so it tends to precipitate in certain organs, and it is a product of purine metabolism. We all know that. Now, in the general population, it has been estimated that 20 to 25% of the individuals are actually affected by it, but only 4 to 6% of the premenopausal females are affected. After 65 years of age, the tendency changes slightly, and both of them are more or less equally affected. It is more frequently found in people who are overweight, obese. So this is what the pathophysiology of hyperuricemia is. So the causes of having increased uric acid in the blood can be actually categorized in, can actually have two causes. One is overproduction and second is under excretion. Now overproduction tends to occur when one has his diet which is rich in fructose, or he suffers from certain metabolic ailments, or there is a tendency for endogenous overproduction. Under excretion could be because of certain mutations in ABCG2 gene, or it could be because of certain drugs which the person is taking. So what does this particular increase in uric acid in the blood do to our body? In the renal system, it causes increased renin, which thereby decreases the nitric oxide which is there for vasodilation in our blood vessels, thereby compromising the blood which flows through the renal arteries, and also decreases the excretion through the renal system. It also causes endothelial and interstitial inflammation. Microvascular rarefactions are seen. Arteriolopathy is also seen, and it also causes interstitial fibrosis. It also activates reticular, it also gives rise to increased reactive oxygen species, which tends to damage your endothelium, and there is also proliferation of vascular smooth muscle cells in the kidneys and also in the arteries. These two mechanisms together contribute for development of hypertension, heart failure, obstructive sleep apnea, metabolic syndrome, and chronic kidney disease and atherosclerosis. Now here we go to the next slide, which is hyperuricemia and its complications. Now it is again divided into two parts. One is symptomatic, the other is asymptomatic. In the symptomatic group, we have something called as gouty arthritis, which can present with acute red joint swelling, painful joint, redness over the joint. Then you can have tophaceous swelling somewhere in the skin around your joints, and also you can have nephrolithiasis because of over excretion of uric acid through your urine. This asymptomatic part includes cardiovascular disease, hypertension, and chronic kidney diseases. Asymptomatic hyperuricemia is defined as a condition wherein the level of uric acid in the blood is high, above normal, but there are no signs and symptoms pertaining to the effects of increased uric acid in the blood. Now, asymptomatic uricemia is pertinent because several studies have shown an association of increased level of uric acid in the blood with disorders like hypertension, CKD, CVD and insulin resistance, and it is as high as 20-25% in males. This particular slide, unfortunately, is not being projected. Asymptomatic individuals are at a risk of nearly 2.7 times more in comparison to normal individual who does not have increased uric acid for development of hypertension. The relative risk for development of dyslipidemia is 1.6 times. It is also associated with obesity, and obese individuals tend to have uric acid above normal, some 3.2 times more than somebody who's got a normal BMI, and risk of development of CKD is twice. Uric acid gives rise to endothelial dysfunction, vascular inflammations, oxidative stress and activation of renin-angiotensin mechanism, which all these mechanisms, they contribute to development of coronary artery disease, chronic kidney disease. Now, the important thing here is that these are vasoreactive hypertension, which is uric acid dependent. Even if you give these hypertensive treatments, and if you don't give uric acid treatment for hyperuricemia, the fall of blood pressure is not to that extent which would have occurred if you have added a hyperuricemic agent for the treatment of hyperuricemia. Then you also have salt sensitive kidney dependent hypertension. The increase of slight increase in salt intake, the hypertension tends to increase far more than what occurs normally in a normal individual. Now, certain studies have shown that asymptomatic hyperuricemia can be taken as a measure or a biomarker for cardiovascular events. 9 mg DL of uric acid carries 3 times higher risk for developing chronic kidney disease, indicating a need for urate lowering therapy. It is also a marker for CKD. For every 1 mg rise in uric acid level, there is an 80% increased risk of developing micro or macro albuminuria over a span of 6 years of follow-up. Now, the incidence of hyperuricemia rises with decline in renal functions. 40 to 60% of patients with CKD 1 to stage 3 actually have raised uric acid levels, whereas it rises to 70% once the renal function declines further. These uric acid crystals, they adhere to the epithelial cells and induce an acute inflammatory response in the renal epithelium. They can also give rise to renal stone formation. Now, there was a study which is known as NHANES, that is National Health and Nutritional Examination Survey. It was a follow-up study which ranged from 1971 to 1992, and it suggested that increased uric acid levels are independently and significantly associated with risk of cardiovascular mortality. It also causes an increase in incidence of stroke and stroke related mortalities. It is also related to insulin resistance because it is directly toxic to your pancreas. Also, there are certain biochemical mechanisms wherein the intake of sugar in the adipose tissue or insulin in the adipose tissue is decreased, thereby at the same level of insulin, the blood levels for sugar are higher. Now, coming to the first manifestation, gout. Now, gout is a disorder caused by hyperuricemia, that results from precipitation of sodium monourate crystals in the joint. It can be an acute gout, and then acute can also be divided into something which is like it's a first episode, or whether it has been happening before also, repetitive or recurrent. And then you have chronic gout. Now, what should we do once you have a level which is higher than normal, that is more than 6.8 milligram per dl of uric acid? So, if somebody has a uric acid of more than 6.8, one must first start from with non-pharmacological therapies such as dietary restrictions, wherein the animal proteins are actually restricted, which also includes shellfish. Then one must resort to undertaking moderate level of exercise and gradual weight reduction, and also avoid certain drugs which can cause hyperuricemia such as thiazide diuretics. Now, if the level is between 6.8 and 8.9 and the person has normal renal function, nothing has to be done. Now, if somebody with a level of 6.8 and in between 6.8 and 8.9 and somebody who has a kidney problem, kidney failure of stage 3 and 4, you must start him or her on urate layering therapy. Anybody who has a uric acid of more than 9, irrespective of symptoms and signs, you have to start urate lowering therapy. Now, what are the detrimental dietary habits or eating habits that we all have, which can actually worsen the level of uric acid in our blood? Animal proteins such as red meat, organ meat, liver, seafood and shellfish have to be avoided at all costs. Alcohol intake of beer can also give rise to increased uric acid. Increased fructose levels or fructose intake will also give rise to uric acid levels. Sudden weight loss will also give rise to increased uric acid levels, vigorous exercise and dehydration. Now, here in our day-to-day practice, we tend to tell our patients that you don't take spinach, or you don't take a lot of proteins, but those restrictions have not been advocated here. Vegetable proteins there are thumbs up, and you can actually ask your patient to continue taking the same. Now, in patients with asymptomatic hyperuricemia with normal kidney function, they say that allopurinol is the first line of therapy, and you should start low and slowly and steadily increase the dose. Stage 3 of renal failure, in due course of time, the decline in GFR was far greater in somebody who did not take febuxostat. So, it tends to delay the falling GFR levels over a period of time. Now, this is another study in which you see that febuxostat mitigated the decline in renal function among stage 3 kidney patients with asymptomatic hyperuricemia without proteinuria. So, somebody who's got higher uric acid without proteinuria, but with stage 3 eGFR, if you use febuxostat, this particular line will tell you that, the one on the left side will tell you that the eGFR is better than somebody who had proteinuria or was not put on febuxostat. There are certain other things which I would like to add, which are not there in the slides. Now, because we are all afraid of somebody suffering from gout or nephrolithiasis because of uric acid, there are certain pertinent points. Now, in the gout, they have staged it into 4 classes. Stage A is wherein the patient has hyperuricemia but does not have any microscopic evidence of monourate sodium crystals deposition in joints. Stage 2 is there is deposition by microscopy or advanced imaging without signs of any joint inflammation or gout. Stage 3 is you have symptoms of acute flares with of course with the radiological evidence, and stage 4 is advanced gout. Now somebody who's got renal calculi, what are the other causes of them precipitating urate stones in their kidneys? Now this is because of acidic urine, of course hyperuricosuria, which is more excretion than normal of uric acid in your urine, then low urinary volume, that means he or she does not drink much water. Apart from that, somebody who has excessive oxidative stress, then somebody who's got insulin resistance because of hyperuricemia, they tend to have more of nephrolithiasis in comparison to somebody who does not have all these. Association with cardiovascular disease. Hypertension is closely linked to development of hyperuricemia, and treatment of hyperuricemia in a hypertensive patient brings down the level of systolic and diastolic pressure further below than what you could have achieved with antihypertensive treatment alone. The possible mechanisms of correlation of hyperuricemia with cardiovascular systems disease are that it is because of oxidative stress, endothelial dysfunction, decreased NO synthesis, then activation of RAS system in kidneys, and increased inflammation. Now what are the drugs that commonly cause hyperuricemia which we all use? Loop diuretics, then anti-tubercular treatments, we all know pyrazinamide and thiambutal, low dose aspirin, then immunosuppressants, cyclosporin and tacrolimus, nicotinic acid, anti-cancer treatment therapies, levodopa and testosterone. In the kidneys, renal hyperuricemia causes both urate and oxalate crystals deposition. Now, whom should you screen for hyperuricemia? Now, somebody who comes with you with a history of acute monoarthritis, which is symptomatically more or less similar to presentations that you have in gout, you must screen them for hyperuricemia. Somebody who already has a history of chronic gout or who has stophaceous depositions, you must screen them for hyperuricemia. Somebody who's come with urolithiasis, you must get his uric acid levels done. Somebody receiving cancer chemotherapies, then the drugs which we've all discussed, somebody who's taking all those drugs or any of those drugs, somebody who's got EGFR of less than 60, somebody with cardiovascular diseases, and somebody with metabolic syndromes. Now the ideal way of taking a sample for uric acid would be after an overnight fast, avoiding ethanol intake, smoking or rigorous exercise, and also drugs which are known to cause increased uric acid levels the previous night. Now certain other pertinent points regarding cardiovascular diseases. Allopurinol has shown to decrease oxidative stress and endothelial dysfunction, which thereby may help lower the risk of atherosclerosis, incident myocardial infarctions, peripheral artery disease, and ischemic stroke. Xanthine oxidase inhibitors have failed to improve ejection fraction and exercise capacity with moderate to severe heart failures. Now the question is, now what are the other drugs that can be given along with urate layering therapy if he or she suffers from some other ailments? Now somebody has got hypertension, you can substitute his ARBs with losartan. You can use a calcium channel blocker. Metformin has uricosuric effect. SGLT2 inhibitors do the same. Statins, they work wonderfully well. Fenofibrate, they also have shown to decrease uric acid levels. Then certain weight lowering drugs such as orlistat, sibutramine, and of course high dose aspirin. Low dose aspirin causes increase in uric acid levels. Another 5-10 minutes. Please bear with me.
I think we will have good discussion.
So this is something very important actually. When should you treat gout?
Go ahead.
Now, when should you treat gout? Now, the patient who's come to you with a joint inflammation, red joint, painful joint, and you strongly suspect him or her to be having gout, what are the guidelines? So, initiating ULT, that is your urate lowering therapy, is strongly recommended for gout patient with any of the following: more than one subcutaneous tophi, evidence of radiological damage to any joint, or frequent gout flares, that is more than 2 flares per year. It is conditionally recommended to treat a gout patient if he has more than 1 flare per year, but not more than 2. That means less than 1 flare per year. So, you can conditionally treat based on how severe his symptoms were earlier, how many joints were involved, or what is his uric acid level. Initiating urate lowering therapy is conditionally recommended against in patients with gout experiencing their first gout flare. So, it is up to you whether you want to initiate him or her on treatment or not, but they do not say that it is recommended. It is left up to you to decide. Initiating urate lowering therapy is conditionally recommended for patient experiencing their first flare when comorbid moderate to severe CKD is present, serum urate levels are more than 9, and urolithiasis is present. Treatment with allopurinol as a preferred first line agent is strongly recommended. Choice of either allopurinol or febuxostat over probenecid is strongly recommended for patients with moderate to severe CKD, because we all know uricosuric agent will cause further growth of renal stones. You should start with a low dose. It could be either 100 milligram or less than 100 milligram of allopurinol and 40 milligrams of febuxostat. Now, choice of pegloticase, which converts uric acid to allantoin, as first line therapy is not recommended at all. Starting treatment with low dose probenecid 500 milligrams once daily to twice daily with subsequent dose titration is conditionally recommended. Now, what are the other treatment modalities in somebody who shows or has a acute gout flare? Administering concomitant anti-inflammatory prophylaxis therapy with colchicine, non-steroidal anti-inflammatory drugs, then steroids over no anti-inflammatory prophylaxis is strongly recommended. That you can use all these things and you can continue using them for 3 to 6 months if you find that the inflammation has not yet subsided or the patient has not truly benefited out of your treatment. Treat to target management strategy that involves urate lowering dose titration and subsequent dose guided by serial serum uric acid measurements to achieve a target SU over fixed dose urate lowering therapy is recommended. That means you should get say on monthly basis you should get his serum uric acid levels test done, and if you feel that the drop in levels are better than what you expected, then you can also bring down the level of or the doses of the medicines that you are giving. Now, what should be the duration of your urate lowering therapy? Continuing ULT indefinitely over stopping ULT is conditionally recommended for patients with in clinical remission taking ULT, that means no flares for more than 1 year and no tophi, the panel considered ULT cessation or tapering. Febuxostat was associated with higher CVD related deaths, all cause mortality compared to allopurinol. So that it is said that somebody who's got advanced heart failure, somebody who's got unstable angina, it's better to use allopurinol. Now one question which was asked to me, which Gaurav had asked, what should you do in patients who's got heart failure, because there you have to use these diuretics, and diuretics tend to increase your urate levels. So there was a study in which they said that if you have to use these diuretics in somebody who's got heart failure, you must use them at low doses. Secondly, all those non-pharmacological therapies pertaining to diet restriction, alcohol restrictions, weight control, exercise, they have to be added. During gout flare, you can use colchicine, NSAIDs, glucocorticoids, and they say that and you can use topical ice as an adjuvant. So the takeaway message is, somebody who has uric acid of more than 9, you don't need to ask any question, you don't need to do any other imaging. Please put him or her on urate lowering therapy. You start low, get serial uric acid levels done, and then you decide whether the dose can be decreased or has to be increased. Somebody who has a uric acid level of more than 6.8, which is the normal level, first and foremost you must advise them to control their diet, alcohol intake, the kind of food that they take, then also take care of their comorbidities at the same time, because both of them, they go hand in hand. And if he has normal kidney functions, you need not put them on any therapy. But somebody who has a uric acid levels of 6.8 to 8.9, has nephrolithiasis, has an acute flare in a joint or multiple joints, has kidney functions which fall in the group of stage 2 and 3 of chronic kidney disease, please put them on treatment. But somebody with the same level without kidney problem need not be put on any treatment. So thank you all for your wonderful time. मैम इसमें एनिमल फूड मना किया है मैम, जो हम लोग बोलते हैं कि वेजिटेबल्स वाला वो नहीं मना किया उन्होंने। एनिमल फूड मना किया है, बियर मना किया है, फिर आपका जो है जो ड्रग्स हम लेते हैं जो बढ़ा सकते हैं उनको मना किया गया है। फिर बोला गया है कि आप जो है मॉडरेट इंटेंसिटी की एक्सरसाइज ही करें, बहुत रिगरस ना करें, क्योंकि मसल रैप्डोमायोलिसिस वगैरह होता है। यू मस्ट हाइड्रेट योरसेल्फ एडिक्वेटली। डेयरी मीट ही मना है। हाँ वो ले सकते हैं सर, पनीर एंड आपका पूरे वेजिटेबल प्रोटीन्स ले सकते हैं सर। हाँ मिल्क ले सकते हैं सर, इसमें मिल्क मना नहीं है सर, क्योंकि मिल्क इतना, हाँ सब ले सकते हैं सर, वेजिटेबल सारा ले सकते हैं। नहीं रेड मीट नहीं सर, बिल्कुल नहीं। रेड मीट मना किया हुआ है सर, रेड मीट मना किया हुआ है, शेल फिश मना किया हुआ है। फिश वगैरह ले सकते हैं आप, नॉर्मल फिश हो गया, चिकन ले सकते हैं, लेकिन मटन नहीं लेंगे। टेबल सॉल्ट से यूरिक एसिड में देखा गया है कि अगर आप टेबल सॉल्ट ले रहे हैं, एक नॉर्मल आदमी में जितना बीपी बढ़ना चाहिए उससे ज़्यादा बढ़ रहा है यूरिक एसिड होने की वजह से, ये बताया गया है। हाँ मैम, हम दाल ले सकती हैं मैम। हाँ ये मैंने वही कहा ना मैम, हम सब लोग मना करते हैं मैम। नो नो Yes, it is because fructose का जो मेटाबॉलिज्म होता है, after it is reduced to phosphate 1 phosphate. Yes. Fruit juices and fructose rich juices, they are detrimental to your health if you have increased uric acid levels. अगर किसी का यूरिक एसिड बढ़ा हुआ है और उसको हाइपरटेंशन है, तो देखा गया है कि आप दवाई दें अगर यूरिक एसिड लोअर करने की भी हाइपरटेंशन के साथ, तो हाइपरटेंशन और जल्दी कम होता है, बेटर कम होता है। किडनी फेलियर वाले पेशेंट में यूरिकोसूरिक एजेंट्स नहीं देने हैं, ये बेसिक चीज़ है।
Dr. Manish,
हाँ सर।
tell me the duration of the treatment of to decrease the uric acid. How long will be given?
सर उसमें बताया ना सर कि वंस यू अचीव अ लेवल ऑफ 6 मिलीग्राम, बिलो 6 मिलीग्राम,
You should stop or you should taper the dose.
सर यू शुड स्टॉप द ट्रीटमेंट, वही बोला हुआ है, बट यू प्लीज एडवाइज हिम नॉट टू ईट दिस 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 दिस, वो सब तो चलता रहेगा सर। एंड यू कैन देन फॉलो हिम अप आफ्टर 2 months or 3 months with the same serum levels of uric acid.
So how long should be the treatment at least initially to decrease, you know?
सर आप तो वो सीरियली कराएंगे ना सर?
15 days, 1 month, what-
सर अगर if he falls in the criteria of treating him, you start him on सर से 40 milligrams of start या 100 milligram BD of allopurinol, फिर आप 1 महीने बाद देखिए कि कितना ड्रॉप हो रहा है, सब कुछ कर रहा है नहीं कर रहा। अगर लग रहा है कि नहीं यू आर सेटिस्फाइड विद द लेवल ड्रॉप, आप उसी को कंटिन्यू करिए। लगता है ड्रॉप उतना अच्छा नहीं है, यू कैन इंक्रीज द डोज फर्दर, 80 कर लीजिए, TDS कर लीजिए। वंस यू फाइंड कि नहीं 6 से कम हो गया, 5 हो गया, तो आप रोक लीजिए।
मतलब 6 से 8 हफ्ता तो खाना ही चाहिए।
हाँ खाना चाहिए सर।
इंसिडेंस एक चीज मैं बताना चाहता हूँ।
हाँ सर।
जैसे यूरेट स्टोन इज नॉट रेडियोपेक।
यस सर।
सो इन द सर्जिकल प्रैक्टिस वी
Difficult.
लॉट ऑफ पेशेंट्स, तो उसको पेन हो रहा है,
हाँ।
और वो कराया, एक्सरे कराया,
नहीं आया, कुछ भी नहीं आया।
कुछ भी नहीं आया, अल्ट्रासाउंड, यू शुड गो फॉर द सीरियस।
यस यस।
Then only you find the uric stone in the kidney, then you get the proper treatment.
Urate and cystine stones both are radio lucent. Lucent.
अल्ट्रासाउंड में तो दिखता ही है।
नहीं सर, नहीं सर,
अच्छा,
वो आपका कैल्शियम स्टोन्स दिखेंगे सर।
रेडियो ऑप्टिक जो होगा उसके तरीका ये है।
मेरे ख्याल से इंडेनावीर स्टोन्स, यूरेट स्टोन्स एंड आपका सिस्टीन स्टोन्स दे आर रेडियोलूसेंट सर।
ये that's right, 60 days में also।
यस सर।
Even अल्ट्रासाउंड में नहीं दिखता है।
The first question is, what is the primary cause of hyperuricemia in most cases? Option 1, increased dietary urine intake. Option B, decreased renal excretion of uric acid. Option C, excessive alcohol consumption. Option D, genetic disorder. First raise your hand and Dr. Pandey will select the first from left.
Increase excretion.
Who is sir? Third color. Second mention, Dr. Sanjeev.
First.
You have mentioned increased dietary protein intake is the right answer. Okay, any other?
Decrease excretion.
Excretion, increase excretion.
That is the commonest cause actually.
Who have given the
Decreased excretion is the commonest concept.
I am taking adequate amount of urine, but I am having hyperuricemia
बिल्कुल।
because I am not getting it excreted.
किसने select किया सर?
ये बड़ा मुश्किल
हाफ एंड हाफ दे कैन शेयर।
I guess you have
नहीं नहीं नहीं, they can आधा आधा खा सकते हैं। Decrease excretion. बिल्कुल, that's the commonest.
So second question is from this side, which medication is considered a uric acid transporter inhibitor used in hyperuricemia treatment? Is it feruxostat, probenecid, lesinurad, or colchicine? Just raise your hand. Yeah. Which medication is considered a uric acid transporter inhibitor used in hyperuricemia treatment?
बताएं क्वेश्चन ऑप्शन।
Feruxostat, probenecid, lesinurad, or colchicine?
The third option is what? Third.
You are not supposed to answer. Please raise your hand. Raise your hand. Dr. Maan.
Option A, feruxostat.
No, that's not the right answer. Colchicine is not the right answer. We'll take the answer from this side, please. There are,
Colchicine is a mitotic
there is one
inhibitor.
option left. Just try your luck. So the correct answer is lesinurad.
Yes.
This is a uric acid
That-
transporter.
बिल्कुल।
Okay. The third question is little easier.
Left side.
So this is from the left side.
I could have asked like that also.
Just hold your breath. It's very simple. Don't be in hurry. What is the threshold of serum uric acid level considered diagnostic of hyperuricemia in men? 5.5, 6, 6.8, 7.
6.8.
Just read to it. So what is the right answer, Manish?
6.8 yeah.
6.8 is the right answer. You just write the line.
Females में they say that
There is some difference in male and female.
yes. Certain studies say that
Yeah, there is little difference. But what is being taught here in ME is 6.8. There are levels which say that. So which of the following condition is not directly associated with hyperuricemia? Option A, metabolic syndrome. Option B, psoriasis, Parkinson's disease, or is it chronic kidney disease? Just raise your hand. Raise your hand. Raise your hand. Doctor, raise your hand. That's the right answer. Parkinson's disease. So last question is.
Low levels are associated with Parkinson's, not high levels.
Last question. Which enzyme is deficient in the genetic disorder Lesch-Nahan syndrome leading to severe hyperuricemia? Option E, xanthine oxidase.
No.
Adenine deaminase. No. Hypoxanthine guanine phosphodiestyl transferase, or it is uricase? Raise your hand. No, this is from this side. Just raise your hand from this side. Dr. Nitin, Dr. Agrawal. Uricase. That's not the right answer. Dr. Gupta.
Third.
Dr. Gupta. Yeah, third is the longest one. That is the right answer. It is hypoxanthine guanine hypophosphoryl transferase. That's the right answer.
तुम्हारा enzyme
Thank you so much. Now it's the time for the certificate presentation, I guess.
So, routinely we should go for uric acid test. Achha, is there any prophylaxis also, like patient is of the age of 40-45 and prophylaxis we should go for a test, uric acid?
Ma'am, if he has comorbidities, if he has metabolic syndrome, if he has irregular lifestyle, if he is on drugs which are known to cause hyperuricemia, if he has kidney problems.
If any condition is there, then only we will go for this test. Routinely prophylaxis इसमें कुछ भी नहीं है ना?
Actually, ma'am, every second person coming to us with raised uric acid levels in whom we did not expect it to be, high. तो उस केस में क्या करना चाहिए? This talk was regarding that. कि asymptomatic hyperuricemia जो आता है, क्योंकि हमने तो उसको
एक्चुअली गांव में ये टेस्ट बहुत होता है यूरिक एसिड,
बट मैं
हमेशा पेशेंट करा के आता है यूरिक एसिड,
लेकिन उसका तरीका सही होना चाहिए, मेन चीज तो अगर आपको लगता है कि नहीं कुछ भी नहीं है, बड़ा हुआ है,
even in severe preeclampsia also uric acid level is raised because the mechanism is same what you told na, activation of renal angiotensin system and preeclampsia, so we get it done sometimes.